My name is Sundeep Kalra. I'm an interventional cardiologist at the Royal Free Hospital in London, UK. I'm sharing a case today just to highlight the evolution in my use of Shockwave IVL, and I'm just going to start going through what my evolution and experience of using this technology has been. The first clinical case I undertook using Shockwave IVL was in 2016, and I've been using it ever since then. My indication for use was for lesion preparation in severely calcified coronary arteries, and I was using the definition of severe calcification as set out in the Disrupt CAD1 trial. So that was on intravascular imaging if there's more than a 270-degree arc of calcium, or on angiographic appearance if there's calcification in both walls of the coronary artery before contrast injection. Since then, since my initial cases in 2016, my experience has evolved and the indication for my use of Shockwave IVL has changed as well. All of the cases I've undertaken have been optimized using OCT intravascular imaging and using a stent expansion workflow, and there have been several observations that I've made from my early experience. Firstly, there were concomitant morphologies of calcified plaque within the target lesion. So that's both concentric, more than a 270-degree arc of calcium, eccentric, less than a 270-degree arc of calcium, and nodular calcium were all often present within the same target lesion. There was not just a single morphology of calcium within the artery I was planning to treat. I also found that treating the entire length of the target lesion and not just the area of most severe calcification facilitated stent delivery and also stent expansion. So that's treating all types of calcium morphology actually helped me expand the stent better and deliver it more easily. And I also found that OCT analysis after the initial Shockwave treatment showed that all morphologies of calcium modified with Shockwave IVL treatment rather than just the concentric only. So if I go on to discuss my case now, this was a case of a 77-year-old lady who had undergone 3-vessel bypass surgery 12 years earlier. Her background risk factors for coronary artery disease include hypertension and dyslipidemia, and she presented to me in my clinic with a 6-month history of worsening stable angina with CCS class 2 symptoms. She was already on 2 antianginals and still symptomatic. I put her forward for an angiogram, and this showed severe disease in her native LAD, severe calcific disease in the mid-vessel, a severe stenosis in the OM2 branch of the LCX, and a proximal CTO of the right coronary artery. The Lima graft to the LAD was functionally occluded, and vein grafts to the OM2 and PDA were both patent. So as we can see on the panel on the left now is the native LAD, and you can see that there is a severe stenosis in the mid-vessel, and on imaging the Lima graft on the right panel, you can see that this is functionally occluded and not actually supplying blood to the LAD artery. So after discussing this lady's case, a decision was made to treat her native LAD with PCI as she had a non-functioning graft to this vessel. So as I normally do with these types of cases where I suspect there is calcium, I undertake OCT intravascular imaging first. And as you can see, using the Ultron system from Abbott Vascular here, there's a high burden of calcium within this vessel. And this is nicely demonstrated with the circumferential display of orange on the right-hand side panel, showing where calcium has been detected by AI. Looking at some of the more specific areas, you can see on the screen now that there is an area of eccentric calcium in this vessel, corresponding to where the white marker is co-registered. There's a 194-degree arc of calcium and its deep wall over 1 millimeter thickness. But this was not the only morphology of calcium within this lesion. As you can see on the next panel, there was evidence of nodular calcium as well. Several calcified nodules within this vessel distal to the area of eccentric calcium. So using a stent planning tool with the Ultron software, I set my proximal and distal markers of the area that I wanted to treat. Distally, we can see that this is a 3 millimeter vessel. Proximally, we're unable to detect the EEL, but on manual measurements, this came up to a 3.5 millimeter vessel. So a decision at this point was to use a 1-to-1 IVL Shockwave balloon, and I used a 3 millimeter balloon. I deployed 50 shocks at the area of nodular calcium and 30 shocks in the area of eccentric calcium. Now on the screen you can see a repeat OCT run after the delivery of shockwave therapy, and you can see that there is modification but also intimal dissection. And on the next panels I'm just going to show some still images of the modification of the calcium. So firstly, we can see in the area of eccentric calcium there are cracks within the calcium that run into the deep wall, and there's good modification there. In the areas of nodular calcium, there is evident modification of the calcium nodules. You can see that there are several cracks running through the nodule, and there has been complete modification of this area of calcification. I went on to predilate the vessel further with a 3.0mm non-compliant balloon distally and a 3.5mm non-compliant balloon proximally, based on the measurements I'd made on OCT. I went on to deploy a 3.0 by 38mm Zion stent in this vessel, post-dilating the proximal end with a 3.5mm non-compliant balloon. And you can see the post-OCT run here. There appears to be good stent expansion and a well-opposed stent. If I take you through some of the still images of this, you'll see that the stent expansion using the Illumin 3 criteria is 93%, and the MSA is 4.25mm squared. So there's excellent areas of stent expansion within the calcified plaque, so that's both within the areas of eccentric calcification and within the areas of nodular calcification. So on the left here now, on the left panel, we see the pre-PCI appearance, angiographic appearance of the LAD, and we can see the post-PCI appearance of the LAD. There's both excellent angiographic and OCT stent expansion. My current practice has now evolved in my use of shockwave IVL therapy. Firstly, my use of it is preemptive and not reactive. So in the vast majority of cases where I use shockwave IVL, I use OCT prior to PCI so that I can identify all areas of calcification. And the cases I select to do this in are where there is angiographic evidence or CT coronary angiography evidence of severe calcification. Occasionally, there's unanticipated undilatable lesions when you embark on a PCI, and in this case, I will also use shockwave IVL therapy, but I will undertake an OCT assessment before I try to modify any calcium. I now use shockwave IVL to treat all morphologies of calcium, so that's concentric, eccentric, and nodular, and not just the original indication, which was concentric calcification. I treat the whole lesion length and not just the site of most severe calcification, which we were traditionally using for areas of concentric calcium. And this methodology has now been supported with data from the pooled OCT data from the Disrupt CAD trials, where we identify that on smaller arcs of calcium than 270 degrees and also on areas of nodular calcium, you can get excellent stent expansion within these areas and good modification of the calcium.